Services. Today's webinar is San Francisco City and County KDA as a catalyst to transition from compliance to improvement. And I'm going to introduce our three presenters today. It is a privilege to have with us today Jennifer Clancy. Jennifer Clancy is Associate Director for Health Care Reform with the California Institute for Mental Health. She has been working in the field of mental health since the early 1990s and currently works as a project lead for a number of California statewide improvement initiatives focused on care coordination and integration. She has served as a project director for 3 Breakthrough Series learning collaboratives supporting behavioral health agencies to improve the physical health status of clients through improved care coordination and increased client self-management. And we also have 3 people from the City and County of San Francisco who we're very happy to have with us today. Sylvia Deporto is currently the Deputy Director of Family and Children's Services Division of the Human Service Agency for the City and County of San Francisco. Prior to this position, she was the Assistant Director for Children's Services Division in Riverside County. Sylvia has over 27 years of experience in the field of social work, including child protective services, services elderly, blind, and disabled adults, and services to developmentally delayed children. Ken Epstein, PhD, LCSW, is currently the Children's System of Care Director for San Francisco County Community Behavioral Health Services. He's worked within family and youth programs since 1981 as a line worker, clinician, program director, professor, and chief executive officer. He has developed and directed comprehensive and integrated community-based systems including crisis services, hospital diversion, wraparound, kinship, school-based, and intensive outpatient services in Massachusetts, Vermont, and California. Finally, we have with us Lynn Dolce, who is a licensed marriage and family therapist. Lynn is the Director of Foster Care Mental Health for San Francisco Community Mental Health Children's System of Care. She has worked for over 25 years as a clinician, consultant, clinical supervisor, clinical director, and teacher. From 1998 to 2013, in partnership with UCSF and San Francisco General Hospital Pediatrics, she developed and provided oversight to pediatric mental health services for children, youth, and families within San Francisco General Hospital's Department of Psychiatry. So before I turn the presentation over to Jennifer, we have 2 polling questions today that we would like you to answer. This helps us to better understand who you are and who our audience is. So we'll go to the polling questions now. So please tell us where you work. Do you work in A, County Mental Behavioral Health, B, County Child Welfare, C, a contract agency or community-based organization, D, an education or training organization, or state government? And if you work in none of those, you could also type your answer into the question box and we will record that too. So it looks like we have 46% are county mental behavioral health, 18% are child welfare, 20% are a contract agency or CBO, 5% are education or training organization, and 9% are state government. Great, thank you. And we have a second question for you. And please let us know the nature of your work. Are you a child welfare social worker, behavioral mental health services provider, a supervisor or manager in child welfare, a supervisor or manager in behavioral and mental health services, a family partner or a peer provider? And if none of those fit your classification, please note that in the question box and we will record that also. And we'll have the results for you in just a second here. So we have 2% are child welfare social worker, 21% are a behavioral mental health services provider, 21% are a supervisor or manager in child welfare, 55% are a supervisor or manager in behavioral mental health, and we have 0 on family partner or peer provider. Great, thank you so much. So we have a good variety of folks that are on the webinar today. Okay, so we're going to go back to our slides now, and I'm going to turn this over to Jennifer Clancy. Go ahead, Jen.
Great. Thank you so much, Kim. And thank you, everybody who is on the call. Always wonderful to have so many people on a call during lunchtime. I want to just give you a sense of where we're going to go in this hour. What we're trying to do is really kind of think about, in San Francisco, KDA and how KDA can actually really become a catalyst to move from these historic child welfare and children's systems care initiatives that have really, really good aims and really good goals, and unfortunately can easily become compliance-oriented initiatives. And so San Francisco really kind of put themselves to task to really think about how can they move from these siloed initiatives to first establishing an integrated aim. And that aim is designing an attachment-based and trauma-informed children's system of care. And then once they have that aim, how do they actually really begin to move toward that? And so that's really where we're going to be focusing today. We're going to talk a little bit about the improvement model, but much of the call is really going to be focused on the specific practice changes, as well as the measurement that San Francisco is using in order to be able to guide some of their improvement work. Next slide. And so Sylvia, I'm going to turn this one over to you.
All right. Okay, so here you see before you a map, kind of a puzzle. We took a stab at looking at the number of things that we do here at the Human Services Agency in child welfare. And these are all the initiatives and service enhancements just from our Family and Children's Services program itself. So while the slide is intended to demonstrate the various initiatives and how all those programs fit together, like a puzzle, it also demonstrates how complex the structure is, and the complexity that both staff and families have to confront all the time in the work that they're doing. And this level of complexity, this maze that you see in front of you, has the potential really to negatively impact our families, because as you can imagine, staff could be pretty overwhelmed by this. Despite the original intention to really make it more clear and to improve child welfare services and increase your system's ability to ensure safety, permanency, and well-being of children and families, it just didn't really, when you look at it, it's a little overwhelming. Next slide. Next, oh, there we go. So, and instead, I think this is where staff end up being, and families feel that same result. Many overlapping initiatives that leave staff just confused and perplexed and bewildered, and that trickles down to the families that we all serve. Next slide. Certainly what we saw, I think what we see the impact on our staff and on our systems, and we've talked a lot about this in the child welfare world, is just initiative and change fatigue. Staff who are overwhelmed with the number of initiatives, and really, you know, when a social worker is working with families, they have a toolbox that they use, and overabundance of initiatives can just overwhelm a social worker, and pretty soon they're just overflowing their toolbox, and they're not going to be able to use all of those tools. They're only going to use the ones that are real familiar to them. And sometimes those that are newer and that are more evidence-based just kind of get left out because it's not what's familiar to the worker, and it's overwhelming to them. The focus also in our agency certainly has become more on accountability and holding people accountable for particular performance measures, like process measures, really, like face-to-face contacts and making sure that court reports are done timely, where we're really focusing on those things and not so much on what are the larger outcomes that we're trying to accomplish with our children and families. And really compliance-driven organizations that have not been able to really focus on improving a children's system of care. So what we really want to be able to do is to focus on collecting data that is used to really translate into measuring more progressive outcomes, and also be able to look at our current performance and be able to evaluate ourselves on our performance when we're looking at larger outcomes like safety, permanency, and well-being, or our children receiving the services and our families benefiting from those services and our children making improvements.
I think we can go to the next slide. I think, Sylvia, you covered it.
Great. And so this was where San Francisco City and County and CIMH began to work together. Once San Francisco had really decided that they wanted to think about how to move from compliance to an actual kind of improvement principles, tools, methodology to guide their work not only within KDA, but really to guide their work within all of these initiatives that have close relationships to each other. And we started to work together. And generally with improvement work, it's often helpful to have an external facilitator because of the reality is you have to change. Nothing improves unless you change. But not all the changes lead to improvement. And I think particularly because the leadership on the child welfare side and mental health side in San Francisco were so aware and sensitive to change fatigue that they wanted to be able to really think about a methodology and a framework that was going to allow their staff to begin to think through the focused changes that were definitely going to lead to improvement and to the ultimate aim and the goals and objectives of this project.
So,
go ahead, Sylvia.
So, we're really moving in San Francisco from these very siloed initiatives that you just heard about to an integrated system that looks at all of the children in San Francisco County that are involved or at risk of involvement for foster care, probation, special education, and for whom they are struggling with complications of behavioral health issues. So we took the step to decide that KDA, while it describes a number of shifts and programmatic shifts that both mental health, behavioral health, and HSA need to make, it didn't really, for us, describe the work that we wanted to do and the intentionality around the partnership and collaboration that we wanted to build. So we took the initiative to stop calling our work KDA and had a more intentional refocus of the work away from the lawsuit compliance to child welfare and mental health, and we transitioned from compliance framework to what we're calling an improvement framework that's going to really give us a practice change that's grounded in quality improvement, theory and methodology with the tools to support it. And instead of calling our work KDA right now in San Francisco County, we're calling ourselves IASC, the Interagency Services Collaborative. And this is a real effort from leadership to really start from the top to collaborate and provide a really integrated service delivery system that meets all of the needs of the families involved with San Francisco foster care system.
And so, Camille, unfortunately, we didn't forward the slide, but maybe we could just forward the slide. It speaks to the issues that Lynn had just been raising. And then do you want to move to the next slide? And then Lynn was going to just talk about the actual aim of the IASC.
Do we have the slide?
Yep. So
okay.
Now.
So from our perspective, what was needed was a real redesign from a siloed approach to a design that really focuses on attachment and trauma, a system that has a shared framework that is information-driven, integrated, and innovative that supports the health, safety, and permanency and well-being of the children and families. And we are looking at, restructuring several different systems in order to be able to do this. So we want to go to the next slide, Sylvia.
Next slide, yes. Okay. And so what IAF does is it creates an umbrella for the child welfare and mental health partnership that we work on together. And what you see here is a number of the different things that exist within San Francisco, but also at a statewide level that we continue to work on. So there's KDA, there's the Affordable Care Act, there's MAST, which is our interagency collaborative. So we're looking at all the things that, even things that are coming down the road, like congregate care reform, and really using our integrated approach to really create an umbrella for integrating all of the new things that are coming our way, as well as the things that already exist. And all of these strategies are based in the same principles and have the same goals, ultimately really to support the health, safety, permanency, and well-being of the children, youth, and families. And the principles, are that services are needs-driven, they're strength-based, and they're family-focused from the very first conversation that we have with or about a family. Next slide.
And so this gives a kind of overarching idea of when you try to think about the framework that's being used. There are two key parts of the Interagency Services Collaborative methodology. What is really critical is that there's both a bottom-up approach and then there's also engaged leadership. And what we mean by a bottom-up approach is Lynn and Sylvia had just talked about the collaborative puts in place this structure so that mental health and child welfare can come together, identify practices they want to change, test and implement those practices. But they are really being able to come up with these ideas based on their own experiences in working closely with families. And so all the ideas for practice change are really coming from, folks who are closest to the families. And so that's the bottom-up side. However, there is also really clear recognition there is no success with bottom-up approaches if you don't consistently have leadership very, very engaged to support those changes, to resource the changes when needed, to really understand those changes within all of the larger kind of aspects of the systems that they're working within. And so, being able to have both parts of the methodology has been, I think, really critical to some of the success that we've already had. And basically, when we get down to the methodology, there are two different things that are happening all the time. And again, this is within this pilot's teams. So there's identification of some fundamental changes. So for instance, a key change that is currently being worked on right now in San Francisco that you'll hear a bit more about later is the child and family team. Many counties are trying to test their child and family team. And so they go through a process where they hold child and family team meetings, and they closely look at what are we trying to change within this child and family team meeting. They go and have a meeting, and then they come back. They have a lot of data, and then they assess, do we need to, what was our learning, and do we need to continue to make changes? And so it's a very, very, very kind of organized process where you have this small-scale testing, but the change itself is a really fundamental change. And then the second part of what occurs within this methodology is this really frequent review of data. So every time the teams go hold a CFT, they're basically doing a small-scale test, and they gather data from that test. They're observing, they're talking with each other. So it's at this point, a lot of it is qualitative data. Ultimately, there's going to be quantitative data as well. And so it's looking at that data that helps them to make the decision, is this change, did this test help us to understand that we're ready to adopt this change? Or did this test really help us understand that, things are improving, but we still need to make some modifications? And so when really thinking about making changes, instead of it being a kind of process of, this sounds good and let's try this, it's a much more measured approach, very informed by data. Next slide. And the overall model for improvement, it's a pretty simple model on surface. It consists of 3 different questions. And so getting very, very clear about what are we trying to accomplish. San Francisco did that before they ever even started with iAsk. They really identified their aim very clearly. All of the parties know what it is that they're trying to accomplish within iAsk. How will we know that a change is an improvement? So that really speaks to measurement. Heavy, heavy emphasis on data that's collected both in using PDSAs and in testing, as well as in collecting measures and frequently reviewing those measures. And then what changes can we make that will result in improvement? And I want to emphasize again, I think what's unique to San Francisco is their commitment to this bottom-up approach. And so they are not saying, all over the state there are, these changes, and let's kind of try to work through all these various changes and kind of see what works here. They're already looking at what has been working and how can they modify that in order to be able to improve it, so that they're not doing the sort of change that has no foundation or connection to work that has historically been being done within San Francisco. So the 3 questions frame their work, and then the fuel, is the way that I think of it, is the PDSA. And so it's a very formalized way of being able to do quick tests of change. You start off by really kind of planning your test, meaning you get clear on what questions are you actually trying to answer. You make some predictions about how the test is going to turn out. You do the test. You do the study. The study is a really critical part, and I really commend San Francisco. They are very focused in terms of taking time after they test to get together and really, across both agencies, identify what was the learning that they had. And then based on that learning, to plan their next act. And so they wind up being able, in a system that can feel very, very chaotic, they really allow this tool to put some kind of structure in place. And so they're clearly seeing what they're learning. Next slide. And so what we're doing,
Go ahead.
Go ahead. Well, just that we're going to move now from, we've spent the past couple of slides giving a little bit of overview of the model, and now Lynn and Sylvia are going to move into, what are these key practice changes that San Francisco is working on testing and ultimately will implement. Sylvia?
And as Jennifer said, the commitment to really testing these and then sitting down and talking about what worked and what didn't is a critical piece of the process. And there were 3 key practice changes that we really wanted to focus on. The first being improved access for families and for children via the child and family team. So how could we put together a team that would have family voice, would have child voice, as appropriate, have family support, and also have the child welfare worker and the behavioral health consultant as part of that team, so that there was more of a team approach to listening and discussing and planning.
And as a result, focusing on the shared family care plan has become a very big priority for us in San Francisco County. The shared family care plan really takes into account now not only the environmental and physical safety of the children that we're serving, but also incorporates all of the behavioral health safety needs that we think the children have. So we'll talk a little bit more about that, how we're sort of coming together and sharing our language around how we talk about and think about and conceptualize around safety. So for child welfare workers, they're thinking about environmental and physical safety, and Sometimes for the therapist and the mental health behavioralist specialist, we're thinking about the psychological and emotional mental health safety of the children and families. So coming together and sharing that language and coming up with one language for one plan for one family is a key practice change that we're really focusing on right now. And that kind of goes along with the shared coaching and supervision model that we are considering adopting and figuring out how that we are going to be in shared supervision with PSWs, behavioral mental health specialists, mental health consultants, making sure that we all are hearing the same thing, getting supervised around the same issues, and have the same goals for the family. Because I think we do in general. We just sometimes talk about it from a different perspective, and sometimes that's a lot of that causes some conflict, and a lot of time gets spent sort of working out what we're really talking about. So we feel that with the shared coaching and supervision model that we create in San Francisco County, we'll be able to be more efficient and more useful to the workers that we're supervising, the mental health specialists that we're supervising, and ultimately, of course, the families that are receiving a coherent service plan. Sylvia, do you want to add anything to that?
No, I think that was perfect. I think the shared supervision is certainly going to be new and challenging, I think, for all of us, but I think it's something that's really important when we're now working as a team and developing a care plan together. And so how do you do that and make sure that everybody's on the same page in order to move that family forward successfully through our system? Next slide. So some of the key practice changes that one of them, the first one that we were talking about, improved access via the child and family team. Certainly, we want to make sure that the biopsychosocial needs of the child and the family are identified by the family themselves. Not that we're coming in there and saying these are what the needs are, but that we really listen to what the child and family are saying about what their needs are, and that that is a critical component of bringing the team together to make sure that their needs are heard from their perspective, and that the child and family strengths that they have are identified by everyone involved, that the family is involved in identifying strengths, the child when and if appropriate, the child welfare worker. We have included parent partners in our child and family teams, which we think are critical to supporting parents and helping parents identify what they are aligned with, not just the strengths, but the areas that they feel meet their needs that they want to work on. Mental health will share the information from the CANs that they're doing with child welfare. Then the child and family will introduce, they'll share the information with child welfare and the child and family, or the CANs will be introduced to the family at the beginning of an assessment process at the meeting. So either the CANs will be done prior to the meeting and we would share that information during the meeting, or the beginning of the assessment could happen during that meeting. We wanted to have some flexibility in how that happened depending on how the family comes to our attention and how quickly they come into our system. There are going to be times when we're going to have to move quicker than others, and so we wanted to have that flexibility. And that was one of the things we learned from our Plan, Do, Study Act, is that we needed to have that flexibility and not be so rigid about that. And then, of course, we would want to have recommendations for reassessment when and if they were needed. Next slide. So some of our key learning from testing, from our child and family team testing, in order to improve the child and family team, staff needed the freedom to really be able to identify fundamental changes to the processes based on their own work experience. In San Francisco, we used our TDM facilitators to begin the testing to see how this would work in a family meeting environment. And then they needed to have a method to test the changes that would remain consistent over time so that the change could be isolated and studied. And so the structure of our biweekly meetings between child welfare and behavioral health is critical because the meetings allow for very focused discussion of the learning that happens. And we are continually trying to adapt our child and family team process based on that learning that we're getting from the folks who are actually doing the work. And there are times when we hit obstacles, or the staff do, in that they may encounter issues that they don't feel they can make the decisions on. There are decisions that maybe need to be made at a different level, or it's the way they've always done it. So we had something as simple as a TDM scheduler who said, well, you know, they don't usually call the family themselves. So that was a decision where that was a point in time where there was some resistance and some, you know, we needed to talk through that and say, okay, well, can we change the model, or how would we change the model, and what would make sense? Who owns the meeting, and who would be the best person to really call the family to kind of schedule that? So it's those kind of things that we're talking through after these meetings happen, and it really is staff-driven because they're the ones that are walking through that process. And that's the data, that's the objective data that we're collecting through that process. After each child and family team, there's a 10-minute debrief where the staff actually complete observation sheets in order to collect that data. And this data then informs the decisions about what our child and family team is going to look like, what are the issues we need to bring forward to the biweekly meeting and discuss and modify if necessary. In the San Francisco model, I said that the TDM facilitators are the ones that have the responsibility and the authority to shape the final decisions of the child and family team, and they're from the child welfare side of the house. But we're constantly in the process of negotiating the roles and the authority and the control, because it needs to be fluid enough so that you can address the different issues that come along. And each family is different, and each scenario may present with challenges or obstacles, opportunities that need flexibility.
The other thing we learned in San Francisco County over the last few years, I think, is that the closer mental health came to HSA, the more co-location we provided to HSA PSW workers, the more need was uncovered. There were a lot of requests. Can you have your mental health consultant at the TDM, or we're having a family team meeting. It would be great if the mental health consultant could be there, or we'd love to have a therapist at the family conference. So we realized together that there were many, many, many meetings that families attend and need to attend, and so we started to talk about, well, gosh, that's just a lot of meetings. It's exhausting for families, and it might be not such a great use of our resources. And it seems like in each meeting it would be helpful to have a mental health consultant present to help support the family or the process in some way. So we're beginning to talk now about how can we take this idea of a CFT, a child and family team meeting, and actually make that what all of our meetings might look like for families, that the structures of the meetings, the family doesn't understand often the difference between a family team meeting and a CFT. We might, but it doesn't make sense to a family. So we're really trying to look at those categories of meetings and what's the best use of our resources, and if we can kind of decrease some of the meetings that the families are expected to attend. And then, again, with our shared partnership, have the right people at the right time in the meetings that they need to be in. So that's that third bubble, number 3, that you're looking at. So the next slide is some of the key practices that we studied in creating the shared family care plan, with the objectives, of course, like I talked a little bit about earlier, that the child welfare and behavioral health plan is an integrated care plan that's informed by both child welfare and behavioral health practice. So, so in our model, we are looking at how do we organize a family plan around family and child strengths that includes the family's goals as well as the child welfare goals and the mental health goals. That we review it frequently. We know that families change. We know that situations change, children change and develop, and the plan also may need to be updated, maybe even every month, because families move at a much faster pace than our paperwork and our compliance reports do. So we need to keep up with the family, and perhaps that means more engagement, and that kind of goes back to that model of an attachment-based, trauma-informed system that serves families, where we're really staying connected to the family and looking more frequently at their needs and tweaking our plan, if need be, to reflect the needs of the family. The 2 models that we're currently looking at are the safety organized practice and transformational care planning. And we are planning to spend a very dedicated amount of time with our leadership teams to learn more about safety organized practice and transformational care planning, to decide how to design a care planning tool that integrates both of the perspectives, both from child welfare and mental health.
And then I just wanted to add that that's another really great example of engaged leadership and how that is really key to the work that's happening in San Francisco. So, you know, before a new change, practice change is ever introduced, there is, you know, really thoughtful and in-depth reflection about, you know, what are the tools that make sense not only within one agency but across both agencies. And how do those tools really meet the goals that we have for children and families. And the ability and the amount of time that is spent both by Sylvia as well as Ken to really, really engage in understanding the models, that not only signals to the staff that this is work that is very serious and this is work that's going to continue, this isn't just sort of a change fad, but it also, again, gives a broader perspective to the changes so that the changes are really moving forward within a context that, you know, leadership understands. Direct service staff are not always going to kind of have that kind of broader picture view.
Right. Thank you.
So really kind of commend the way in which you guys are moving forward with trying to think about these changes.
Thank you. And another tool, if we go to the next slide, another tool that we are thinking is going to be very, very helpful is what we talked about earlier, a shared coaching and supervision model. And this is both a framework and a model that is, of course, focused on the child and family's strengths and capacity to meet their goals with our support, but it also focuses on the people involved in helping the family. So the PSWs and the mental health specialists also have needs that we need to really begin to look at and address if we want the families to be successful. So bringing people together, developing strong relationships, keeping people engaged with each other isn't just the work of the therapist with the family. It's the work of our leadership and our supervisors with the people that we're supervising and training all of the time. We really want to foster, develop, and role model that strong relationships are central to healing. And we think that by using a model of reflective supervision, we'll be able to do that in supervision together in teams, where we're really modeling ourselves as supervisors that we care about the people that we're supervising because we care about the work, we care about their well-being, and we're going to ask them to be just as reflective about their work as we are about their work, as well as, you know, we ask the families to reflect on their lives all the time, but where do we get a space, where do we have a space to do that for each other and with each other? And we think that reflective supervision is going to be a very key tool in our practice change around how we, you know, that it's the difference between being in compliance with the family care plan and making that practice change so that people feel good about the work that they're doing and that they're doing good work. That's also monitored and, valued for, yeah, I'll just leave it at that. So, Jen, do you want to look at the next slide, or did you want to add anything?
No, I thought that was great. So these are the measures. The data that we have been talking about thus far, again, is the data that we have been collecting from doing the PDSAs themselves. In addition to that data where you're really getting data, PDSAs are run really quickly. So every day there is a lot more data that the San Francisco can work with and try to better understand their change processes. And then we also have some broader both process measures as well as outcome measures. And so we just wanted to identify kind of quickly what those measures were. The process measures are looking at whether or not we actually have the sort of teaming happening within the CFT. That was an original intention of the CFT. Do we have consistent participation from child welfare and mental health and the parent partner? We've had lots of learning about how much has to be attended to in terms of structure and logistics to ensure that that happens. And then the number of children in the target population who have a shared child welfare and mental health family care plan that was updated within the last month. So, really looking at both process, do we have this shared tool? And as critical, kind of thinking back on Lynn's comments a couple of slides ago, the frequency of the updates. Is that care plan really driving the care that the child and family are getting? And then the 4 outcome measures are measures that have been traditionally collected within the CWS system. And so, looking within the target population at the number and percent of children re-abused, we're doing number and percent just because the target population is potentially small, so we didn't want to do only percentages. So we're looking at the number of clients who were in family maintenance at case opening and have not since been placed. An outcome measure related to permanency, how many kids in the target pop have actually achieved permanency, and then looking at the number of children in the target pop who were in a family maintenance program when their case opened and who have since spent time in a group home. And the goal is, again, sort of really recognizing that not only a data collection tool that will then generate good dashboards that are easy to read and easy to understand and easy to study as a group. Developing that tool took a bit of time. And then establishing a process by which we are moving the data that is coming out of CWS, because all of this data is in CWS and then gets transferred to an Excel file, and the Excel file generates the run charts or dashboards. And so we are continuing to finalize that process, and the goal is to be able to monthly collect these measures beginning July 1st. And so at least one of our team meetings each month would be dedicated to looking at the data via dashboards. So the depth of the Interagency Services Collaborative will grow as we move forward because we will have more sources of data to really be informing, the key question, are these changes leading to improvement? Next slide.
So our pilot teams that we've been referring to are, we have 2 different teams. We have a Spanish-speaking team and we have an English-speaking team. We have approximately 10 child welfare and behavioral health staff in each team. And like Jen is saying, we meet regularly. We meet twice a month, and then in between when we know we have a child and family team meeting approaching. And the teams were basically initiated by, on the mental health side, we asked for volunteers. So we really wanted people who kind of felt committed to the process of change and who felt like they could actually have the bandwidth to participate in all the meetings and dialogue. So we had our 2 volunteers, and then we asked for people from HSA as well to step up and volunteer and participate. And it's been an incredible experience, I have to say. It's just a wonderful, wonderful group of people who are piloting all the changes all the time and communicating really well about it. As Jen said, we've got our data collection process beginning officially on July 1st. And Sylvia talked a lot about the PDSA testing of the CFT model. And it really is informing how we're thinking about this. So again, no major policy or procedural changes have been implemented on either HSA or mental health at this point because we're still testing what the changes are going to be. So again, the pilot teams are really informing through the PDSA process how we're going to be implementing the big systemic change. We are in the process of having the discussion, as I said, with all of the providers about the different kinds of family and team meetings that the families are asked to participate in, and we're considering what makes sense both for the families as well as for our compliance issues, but in the name of making the key practice changes that we're committed to around a trauma-informed, attachment-based long-term care coordination model. And Sylvia, do you want to talk about the leadership retreat?
We have a leadership retreat that we're planning at the end of June, and our focus of the leadership retreat is really to focus on the next steps that we need to start testing, and that is, what does a care plan going to look like? What is it going to look like? And what is the best model that we want to put forward, and how do we move forward in integrating what is typically a child welfare case plan and then a behavioral health care plan? And what our hope is to come out with something that we can test and put into place and take through our PDSA process. We're also planning on looking at what are closer at our coaching and supervision models, the safety organized practice, and reflective supervision, and the all these things that we said earlier, the transformative care planning, are all going to be a part of this discussion. So we can really look at how do we develop that care plan, but also how do we provide for joint supervision and teaming in our supervision and our coaching of our staff through this process.
So in foster care mental health, over the last 7 months that I've been the director, I have really benefited from all of the learning that has gone on in the PDSAs, because everything that we're learning from the ground up has been, we've been using to shape our, the restructuring of foster care mental health to really meet the needs of what HSA needs from us right now, what the children and family needs from us right now. So foster care mental health in San Francisco County has a long and wonderful history, about 18 years of working and serving children through the HSA system. And we have an opportunity now to make some key practice changes on the mental health side. And in order to do that, we are restructuring the entire foster care mental health business, if you will. So in order to avail our staff to the CFT meetings, in order to get the kids assessed within 2 to 5 days of coming into contact with HSA, in order to provide mental health consultation to the PSW or to any provider that's working with the child, we're really looking at a very different model of functioning here at foster care mental health. The number of referrals that we are receiving as a result of KDA, and then as a result of our new IASC model in San Francisco, I think we've almost doubled the amount of referrals. So we've really just looking at the infrastructure and figuring out how do we best use our mental health resources to meet the needs of the children and families. And we are doing a great job. We're about to roll out a whole new plan in July on how to do that. And it's only been because we have this amazing partnership with HSA right now that we've been able to kind of get this far in the last, I would say 7 months, that we can actually start making these practice changes here at foster care mental health. It's very exciting.
Extremely. Was there a last slide for questions? Camille?
Yes, we do have a question from Jeff. Are mental health staff doing the MHST in San Francisco County, or are the CWS social workers doing the MHST?
What is MHST? Mental health. Does anybody know what MHST is?
I think it's the MIST, which is an assessment tool.
Oh, okay.
I think.
So, okay. Jeff, if it's the assessment tool that Sylvia is referring to, then no, we are not using the MHST. We are using the CANS, birth to 5, and we're using the CANS 5 to 18. And then for the little ones, birth to 5, we're also using the ASQ screening.
Okay, and then the next question from Jeff is, sometimes CWS social workers see this as a barrier to mental health services. How can we handle that frustration?
I don't think I understand. See what? Using the screen? Or I'm not sure I understand the question, Jeff. I'm sorry. What is the barrier?
I'm going to wait for him to try to respond back. But the next question says, who facilitates CFT?
Right now, those are facilitated by our TDM facilitators. So our team decision-making facilitators are facilitating our child and family team meetings at this point in time. Remember, we have 2 teams that are piloting, so we don't have the entire agency rolling this out yet.
Holly has a question. What are the caseload numbers of the workers? One moment, sorry. Workers that are piloting.
Which workers, the behavioral health workers or the child welfare workers?
She wasn't specific, so I'm going to assume both.
So on the child welfare side, our teams consist of a full array of child welfare workers. So we started with ER workers, we had court dependency workers, and adjudicated services workers, so family maintenance and FR case carrying workers involved, as well as our TDM facilitators. So we have a whole array of workers. Our ER workers probably average around between 8 and 10 referrals a month. And our CDU, court dependency workers, probably 2 investigations a month, and then our case-carrying workers are around between 15 and 20 adjudicated cases.
And so for mental health, the mental health consultants are holding about 18 to 20 CANS assessments in any given time. At this point, the teams at foster care mental health will be multidisciplinary and multifunctional in that everybody will be doing assessments. Everybody will be doing the case managers and linkages to support the HSA care plan. And the teams will be holding at any given time several hundred children and families, so that over time we will, at foster care mental health, have the entire history of the child and family when we need it as the child moves in and out of the system. So that because the social workers at HSA change somewhat frequently, we want it to be the steady home base. This is the attachment model that we're talking about, where foster care mental health actually holds the history of the child and family's mental health needs. So our teams will be accumulating hundreds of families, almost like an HMO, if you will, in the best sense of the word.
The next question from Miracle is, she just wanted to reiterate, well, why don't you guys reiterate, why did you exactly use IASC instead of KDA for a title?
Well, we really wanted, we're trying to get away from the whole new kind of initiative thing. I mean, I think we talked about initiative fatigue and just the complex puzzle that you saw at the beginning of all the things that were going on in the Human Services Agency and all the different services and programs and initiatives, and how that can just be overwhelming to a social worker, and that really does trickle down to the family, and they can become just as overwhelmed with that, all that chaos is what I would call it. And we didn't want our implementation of KDA to just be around the lawsuit and what the lawsuit was requiring. We were really looking at more of systemic change and just really kind of looking at the entire system and saying, how can we better serve children and families that come to the attention of both child welfare and behavioral health? And how do we do that together in a way that makes more sense for children and families, that facilitates a smoother relationship between our agencies together, but also between our agencies and our families? And how do we be able to move families forward successfully through our systems? So we were really looking at system change, and we didn't feel like KDA was about system change alone. We felt it was broader, and so we wanted to give it a different name. And so when we thought about it, it was really about two agencies and collaborating in a different way and working together in a different way to serve the needs of the families in our communities. Lynn, if you want to add.
Oh, no, that's perfect.
And with the initiative, are you guys including birth parents, or is this primarily just for foster parents?
Oh, no, this is for birth parents.
Okay. And then the next question is, are you doing a mental health screening for every child prior to doing the CANS?
So the CANS, what we are doing in San Francisco County is we've taken the long CANS, and we've been able to pilot a shorter version of that CANS, and that is our screening tool. So every single child who is open with HSA has a CANS screening to determine whether or not the child meets medical necessity for any other mental health services, or if we know right off the bat that the child needs to be part of the subclass. So everybody will get an initial CANS screening, and then after 30 days, that gives us time to consult, have a child and family team meeting. Once that child is identified as meeting medical necessity, that child will then have a full CANS assessment somewhere in our community, either with a private provider or CBO or one of our community clinics, and then that child will then begin receiving the mental health services.
The next question is, so are your CFT facilitators and your ICCs two different people? Or is one a CW and is the other one just for mental health?
Sylvia, do you understand the question?
So are the child and family team facilitators the same as the intensive care coordinators?
Oh,
yes.
Is that the question?
Yes.
No, the child and family team facilitators currently are our team decision-making facilitators, which are child welfare employees, and then the intensive care coordination is coming out of the behavioral health.
And for some of the children, for the children that are in the subclass already in San Francisco County, those child and family team meetings are facilitated by the intensive service coordinators that we contract with. But they are not part of this pilot right now. So they have been doing child and family team meetings for the subclass of our child population in those agencies.
So we are planning to meet with them to be able to begin to integrate sort of what they're doing with the learning that's happening within the county.
Right.
So I think we have time for about 2 more questions, Camille.
Okay, the next question is, what training materials are currently being used for foster care families, parents involved in the system, and in the staff to facilitate attachment-focused trauma informed model? Sorry.
That's a big question. So the first two parts, Sylvia, I might have to leave to you, right? The training materials for foster parents? Is that the first part of the question?
Yes.
Okay.
Yeah, I just so the Bay Area Academy does do some training for foster parents on trauma-informed care and practice. I think overall the plan, and Lynn can speak broader to this, is that behavioral health has developed a pretty comprehensive curriculum that they've trained their entire agency on, and the plan is for child welfare to then be trained on that same curriculum, and then we would like to roll that out to all of our community-based providers, which would include foster parents and anybody else that works with our children and families. Lynn?
Yeah, so in San Francisco County's Department of Public Health Director, Barbara Garcia, has asked a team of us to create a curriculum to train the entire Department of Public Health. So not only the CBHS, the Community Behavioral Health Service providers, but also the entire Department of Public Health, including IT workers, HR workers, providers, MDs, nurses, anybody in public health, in a trauma-informed system of care curriculum that we're currently rolling out. We've got 7,000 people to train. I think we've trained about 600.
You're making good dents.
We are making good progress. This training then hopefully, as Sylvia said, will be offered to HSA, and maybe at some point in the future, in the next decade, San Francisco County will become a trauma-informed city, perhaps like Philadelphia or some other cities in the country, but that is our hope and that is our goal. So, and that curriculum dovetails really nicely with the supervision model and the attachment-based trauma-informed care coordination model that we're thinking about, that we're implementing here in San Francisco County. So it's not evidence-based interventions that we're talking about. We're talking about total systems change in San Francisco County. We use all the evidence-based interventions in mental health treatment with our providers, and we have all of those trainings, and I can talk more offline with anybody who wants to know what those best practices are. But what we're really looking at in San Francisco County overall is a culture change around how to be trauma-informed system and a city.
The final question is foster care's mental health doing only assessments in case management?
No. Foster care mental health has also a team of clinicians who also do therapy, individual therapy, group therapy, family therapy. Right now, our focus is on really meeting the KDA compliance, that every child has an assessment that comes into contact with HSA. So we're really focused on meeting that compliance effort, as well as then making the practice change. So we do the assessment, we do case management, we do therapy, and we'll be looking at how to, what is our identity going to be as a clinic of therapists, that's sort of the small part of what we do at this point, because we're really focused on what the practice changes are going to be around the IASC implementation in the county. But we are very committed to providing the clinical care whenever possible and serving as a mental health consultant whenever needed for HSA.
Great. Well, listen, thank you so much. I want to thank all of our presenters here today, Jennifer Clancy, Sylvia Deporto, and Lynn Dolce, for their very interesting presentations and really modeling some really great collaboration between different departments. We are at the end of our time. We've run a little bit over, so thank you for staying with us. There will be a few questions that will pop up on your computer as you exit, and those are evaluation questions. Those really help us inform our work and help us give us feedback, so we appreciate that. So once again, thank you again, and with that, we will conclude our broadcast, and thank you for joining us. Goodbye.
Thanks, Kim. Bye-bye, everybody.
Thank you. Bye.
Bye, Sylvia and Lynn.